Welcome to School. My name is Dr. Liam Clark, and tonight I am presenting on red flags in headache, or when should I worry about my headache, what to watch for, and what to do about it. So I'm currently a headache fellow at the University of Utah as of 2023, and I like doing these talks because I like talking to people and educating them and getting you a sense of empowerment, and hopefully you come away with practical knowledge that's useful for you in your life. Um, Headache patients can watch this talk and understand their own headaches better, what to look for, friends and family, anyone worried about new headaches in themselves, or anyone who's generally curious about headaches. Now, there's basically famous criteria for what are red flags that are called the Snoop criteria, which is why there's a picture of Snoop Dogg there. And we will go through kind of them in order. I've grouped them together to try to make it easier to remember, and we'll explain some of the technical things that are helpful to understand as we go. So the first couple we'll talk about are systemic signs and neurologic deficits or dysfunction. Okay, so what does that mean? So fever is a big one, weight loss, neck stiffness, confusion, decreased consciousness, which means someone isn't as alert or as aware. They're hard to wake up or they don't wake up at all. Weakness, typically just in one area of the body is when we get more worried, but overall weakness is still concerning if it's never happened before. New numbness or tingling, slurred speech, sudden dizziness, especially if they're abrupt, hallucinations, difficulty walking, and vomiting. So all of those fall into the systemic signs or signs that are affecting your whole body and neurologic dysfunction symptoms. So there's a bunch of things that we think about with this, and they tend to be fairly dangerous or concerning, which is why this is kind of the top of the list. Meningitis, either from bacteria or viruses, encephalitis, which is more than meningitis, it's an infection of the brain tissue itself, a brain abscess, stroke or bleed in the brain. That's why I have the picture on the bottom, which is the FAST acronym for strokes, facial drooping, one arm is weak, speech is slurred or garbled, and then that means you have to act quickly and should go and seek emergency care quickly. Vasculitis is another thing that can mimic these things or act similarly, autoimmune disease, and there's lots and lots of other possibilities, but most of these are going to be quick onset and have significant, noticeable, abrupt sort of symptoms that are new. The next couple that we'll talk about is more having to do with past medical history or sort of stuff that may be something that you personally have. History of cancer or immunosuppression is kind of what I'm grouping that under. So there's a couple things to go into here and need a little bit of background to really understand that. So bleeds and vasospasm can cause pain. So we call that the thunderclap headache. That's the worst headache in your life. It's sudden, comes on. Either of those things can cause abrupt, really severe head pain. Masses in the brain can also cause pain. A lot of patients are worried, is this a tumor? You know, what am I going to die from brain tumor, which is very understandable. But those pains tend to come on slowly, if at all. And other things that are masses in the brain can cause exactly the same kind of pain from an infection or an abscess or a clot or anything else that can take up space. So to answer the sort of elephant in the room, the risk of finding a brain tumor in any given headache patient is 0.1%. That's why I have this picture of this worried woman on the internet looking and Googling and reading about things, because it's pretty unlikely. But if you have a history of cancer, it's a lot closer to 25 to 50% if you have a new headache in there being some kind of intracranial brain tumor sort of situation. And then on the top of that, about 25% of stroke patients can have a headache along with their other symptoms. And sometimes, very rarely, it's the only headache or it's the only symptom that they have. So when we say we're looking at sudden onset, history of cancer, immunosuppression, the kind of diagnoses we're thinking about are stroke, subarachnoid aneurysm, or subarachnoid hemorrhage. So what people often talk about when they are talking about an aneurysm is a brain bleed. And then there's a couple acronyms there that we'll get into in a minute. Cancer we touched on, HIV, leukemia, etc., chemotherapy and other immunosuppressive drugs like you might be on for MS or other reasons. Those are important because they can increase the risk for infection. So that is the kind of mass or that space filling process. And you're less likely to see the systemic signs that we relied on the last slide, like the fever and typical signs of infection. So taking a minute to talk about those acronyms and a little bit of anatomy about why headache happens from secondary causes, which is what we're talking about today mostly, is not a primary headache disorder. So intracranial hemorrhage, there's lots of places it can bleed. It can bleed around the outside of the brain, right underneath the fine layer clinging to the brain, inside the brain tissue, outside of the protective layer of the brain, but inside the skull. All of those have different causes, of course. RCVS is reversible cerebrovascular constriction syndrome, which is basically blood vessels that spasm in the brain, as we talked about a couple of slides before. CVST, cerebrosinus thrombosis. So here's the arterial system with all the arteries, and here's the venous system. So you have these veins that catch the blood draining back out of the brain, and those can get clots in them, which can increase the intracranial pressure and cause headaches. And over here at the top is the cerebrospinal fluid circulation diagram. So you can see the CSF goes up and around, it bathes the brain and it cushions it. But if it can't circulate properly by reabsorbing back into the venous system, it'll build up and cause some difficulties. Then the next middle section here. So older age, pattern changes, position, provoked by Valsalva exercise, post-traumatic and progressive. So these are really patterns, which is what this picture on the other side is for. You're seeing a change in the pattern, a shift in the pattern. So new headache when you're over age 50 or 65, but 50 is what we say now, is a major contributor to being a little bit worried. Maybe you've had headaches before, but if you have a new and different kind of headache, then it becomes something to seek help and talk to your doctor about. Other pattern changes include it being more frequent, having new features or symptoms, having a different kind of pain or location of the pain, different triggers, having morning headaches that you didn't used to have. And then progressive is it's constant and gradually getting worse over days to weeks. All of those are warning signs. Positional headaches, typically we think it's worse laying down, but in some cases when it's worse when standing up, when that's reliable, that's also something that requires a little bit extra evaluation because we think there's a problem with the CSF flow. A headache that's provoked by Valsalva, when that what is bearing down, coughing, laughing, when you're kind of trying to pop your ears, that's kind of that idea. Or with exercise, we sometimes think about Chiari malformations, but they tend to usually be asymptomatic. So that kind of maneuver, still you should mention it to your doctor if that's new, that is causing headaches. Post-traumatic, typically right after a trauma, you fall down off a ladder or get hit in the head in a sport, and you immediately have a headache. That can be concerning if it doesn't resolve in a minute or two, especially if it's a tall fall or a bad fall. But you can also have post-traumatic headaches that persist. So if you still have a headache more than a week after a concussion or another fall, it's worth seeking advice and help because you don't want to get into a long-term pattern of post-traumatic headache. I developed a whole slide just to the pregnant and peripartum issue. So there are a lot of changes that happen in and around pregnancy, hormonal changes, increases in blood volume. People can feel very sick to their stomach and vomit a lot, get dehydrated. And all of those increase your risk for some of these secondary headache types that we've talked about so far, like the cerebrovascular constriction, the clot in the veins, eclampsia or preeclampsia that can happen during pregnancy, can cause high blood pressure, what can cause headaches. And there's also a risk of stroke around pregnancy, which can cause headaches, as we talked about before, because of the changes in coagulability that can happen or bleeding during delivery. But also epidural anesthesia is very common in delivery, and that can actually cause a low pressure headache. So we're looking at those patterns, new headache, different symptoms. Those are the kind of things that you want to seek help for. And then after, in the peripartum area, after delivery, hormone changes, blood volume and coagulability changes kind of reverse, but it's still turbulent. So you're still at risk even after you deliver. The last couple are about the eyes. So papilledema, painful eye with autonomic features. So what is papilledema? That's the swelling of the optic disc. This picture on the right has the different grades of papilledema. That's what the doctor sees when they look in the back of your eye. Often the eye doctor will dilate your eye to get a better view. Those signs is signs that swelling is happening in the brain. There's more fluid in the brain, and it backs up along the pathway of the optic nerve, as you can see in the picture up on the left. So it pushes up against the back of the eye. There are a bunch of different potential causes for that, but it can threaten vision, and it can cause irreversible vision loss, which is why we like to treat it promptly when we do identify it. The other thing to look for is the painful eye with autonomic features. So you have this one eye typically will tear or run during the headache, or one nostril will feel congested or run. The red injected, as we would say, eye looks very much like this picture. You have the blood vessels standing out. People can also develop a droopy eye, we call ptosis, or puffiness around the eye, we call edema. Flushed skin, often just in one part of the face, can come with that, as well as sweating or a dilated eye. Many of these things usually only happen on one side of the head during a headache. Any of these signs, though, can be indicative of eye disease or another problem in the brain or eye. So if it's new, it prompts another doctor visit, some more evaluation, because anything that affects the eye can risk vision loss, which is often very hard to reverse and salvage. So to kind of sum up, to take that, all together, there's a few themes that even if you don't remember all of the Snoop criteria, you can think to yourself, do these new symptoms or does this headache fit with any of these themes? And if it does, then you reach out to your doctor or even go to the emergency room. So if you have a change in pattern, it's worse, it's more frequent, it's happening when it didn't used to happen. If you have new symptoms, particularly neurologic symptoms or systemic symptoms, like you're sick, that's the thing to really think about when you go to the emergency room. If you have a new sudden onset of symptoms or you're really getting sick, go to the ER, don't wait around. And then if it's worsening, if you're like, oh, I don't know, it's kind of getting more frequent or worse, and then it becomes constant, and then it becomes more painful, those are not good signs and should prompt you to go and ask for help or seek someone to help you. If it's quick onset, comes out of nowhere, that's also more of an emergency room thing. And then if you have a history of kind of medical complexity yourself, like cancer, immunosuppression, those are the kind of things that just increase when your suspicion when you have a new headache or have new symptoms. Just be a little bit quicker on the trigger to talk to someone and let them know. And if you only take one thing away from this whole talk, it's the changes in pattern of headaches is really the thing to pay attention to. All of these other things fall into changes in pattern. So if you don't remember anything else, remember, is this like my usual headaches, or is this a different headache with new symptoms and new features? That second one, that's more concerning. So hopefully this was helpful to people out there. We love it when people come and watch our videos on Headache School. If you can put questions down there, sometimes we're able to respond to those. But share with your friends and tell them about our program if this was helpful for you. Thank you very much.